I signed up. That's exactly. Like I would, so I'm trying.
Almost emailed you again.
Yeah. No, because I knew I was gonna do it, I just allowed it, I got kind of behind on the emails, like everybody wanted it like all at once, and then I was like, okay, now I have to go back, and then I did it. I know that feeling. Yes.
That's there.
Right.
Are you going to have it?
Yeah.
Oh, number.
I was gonna say,
It's not even.
sorry.
Mark isn't even the worst. It's only it's from like. Exactly. But.
It's value too.
Yes. How they know. Teachers.
Yeah.
So they're going to send it to you.
A lot of times do I get an email from so, you know, I get an email, a text message, and a parent's for a notification. Or you can have yes, every single thing in a free notification.
Yes. And they can go to.
Do you have a license? I have a license for.
I have the same one from, is it the same one from?
Oh,
That's what I.
We'll I have a message.
So one Tara, she's the one who sees them, so she was like screenshots.
Well, I know I
And I'm just like, there's no shoe like number. I don't even know.
I haven't had that. Like what?
I just said like,
Like they don't just emails in time and everything.
Yeah, I mean,
I get calls at like 5 o'clock in the morning. Which is always fun messaging.
if you do it now, then I can do it before we start.
A phone call.
I get a phone call and text and an email every day.
Yes, that is.
Yeah.
Well, and what's interesting is apparently my daughter has time, so what I do is call them. Anything.
Because my doesn't get somebody. So
That's practice.
Hey, I'm trying to figure out how.
Hello.
I'm trying to figure out.
Actually, so it wouldn't be hard, you know, if you emails that we had, just switch over to a go through the.
I just messaged Kara and asked if.
No, I'm not, I feel like I'm not sure.
How are you?
Really?
Yeah, well, the count. Daytona Beach. That's where we're going. Well, stay tuned.
Well, we're gonna get changed.
Don't fight for nothing on the.
What?
Lisa. It was which we used to say Mike and Max.
And there's
It's been on the other side. Like you have to see something.
Yeah.
Just big dress. Slide it down.
Yeah. So I try to make my phone be quiet.
Here.
Well, welcome, everybody. Oh, come on. I never get this many things. Thank you all for making it here today. And I don't know how many of you drove through the unexpected little snowstorm that happened earlier this afternoon, but thank you for coming through that. So, and welcome to everyone attending virtually. I see faces. So thank you for joining us today.
Microphones are for the people out there to hear you. It's not gonna make any Wasn't here, if I'm understanding correctly. But-
Okay. Okay, can you all, because I was always worried about blasting people if it's too loud. So can you all hear the virtual attendees? Can you hear me?
Yeah, we can hear
And
good.
everybody else who's going to talk? Okay, thank you. Trying to pull up the agenda.
I have a copy.
Oh, thank you. Okay, great. Well, this is the official welcome. Welcome to all the attendees who are not members. I'm always glad to have you here, and we're always open to input and thoughts. So, and everyone who's on MHAPAC who came today. It seems like it's been a long time since the first of the year, but yeah. So I hope everybody had a good winter and is doing well and staying healthy. We have several great presentations today, and I think we're going, sorry, you're gonna have to keep reminding me to do this. So, and I think we're gonna begin with the application process for MHAPAC. See, yeah, you had to do it too.
All the presenters, sit right here.
I don't think you have one yet.
Thank you.
Awesome.
Am I okay? Can you guys hear me? Good. Okay. Last session, Sarah had spoke about needing to add more members to the board that had lived experience. So that is where the application process came from. It's a simple application that we had sent an email out on March 9th. Closed the application on March 16th because we had 105 applicants, 59 of which are eligible. We're going to look at what county they're representing so that we can have a wide variety of people, as well as if they're lived experience, family members of lived experience with mental health or addiction, their reason for wanting to join MHAPAC. And then once we have a shortened list, we'll send it to Sarah to look at. And then is it Secretary Robe? Secretary Robe is the one who will pick the official members that will be added. So this is a quick thing of the application. Anybody have any questions?
Where was it posted that it got that kind of response? That's
Oh, I
cool.
did have one. If somebody was an IRC member, do they have like any kind of, they're more likely to be chosen since they've already been participants in the recovery space? I was just curious.
Now, if they're behavioral health or like an addiction provider, they will not be selected.
Well, that's a lived experience.
Just the lived experience board. What do you think, Sarah?
I mean, I don't know that it will, I guess I'm not sure how to answer that, right? Like, I really want the playing field to be level and everybody to have an opportunity, but we also have to think about the different roles, right? So there's going to be so many seats for family members of children, so many seats for family members of adults or people with lived experience, right? So we have to kind of balance it, and I haven't seen where those fall out and how many applicants we have. So
Okay.
kind of hard to answer that right now.
Groups or recovery groups or any of that at this time. But I feel like it's something we could discuss.
If they're employed, but.
Employee, well, I had also put if they are just a part of a peer group. So that 59 doesn't include those. The 105 is the total amount of applicants.
Okay.
So 59 is anyone who's not a part of a peer group, not a behavioral health policy provider or addiction provider, anybody employed by those. So we can look at the numbers again, but.
Okay, so we're like a little more weight to people who aren't like CPFPs, but just have the lived experience, but aren't in the space.
Correct.
Okay.
But that can be looked
Yeah,
at
but
differently. Yeah.
I mean, I guess it depends on if they're employed, right, by a provider,
Okay.
and they have an income by a provider, then that's gonna be challenging
Okay.
because of the rules.
And I think like Sarah said, because there's several new categories of representation we have not had on MHAPAC, that, we're going to be focusing on getting input from more groups of persons.
Good.
Any questions out there?
I think it's pretty straightforward.
There's a message on T or question on Teams. Chat. I do not have the.
Oh, I left my phone over there.
Sorry, yeah, I just was asking, that response sounds awesome. Where did we post it to get that kind of response?
It's great that we got that kind of response. Where did we post it?
It was an email that was sent out to our listserv. And then also anyone who worked for DMHA could send it out to a provider, or anyone else they felt may be a good fit.
I also shared it on LinkedIn and I think we got a lot of traction on there, right? With different people sharing my post from there. So I think hopefully it went out and it spread pretty far. I think that our next decision is like, how do we keep it open, right? I know you closed it at this point just because there were so many coming in, but is it a list that we keep ongoing and just communicate to people? We've talked about when someone's not selected, how that communication is going to go. And so inviting them to be maybe not voting members of MHAPAC, but engage in the process and be in the room for dialogue and conversation. So lots of decisions still to make, and happy to have that conversation with you guys about if you've ever had these experiences or thoughts about how we keep the application pool fresh, right? But then not people just lingering and waiting for too long.
And just to give an emphasis, like there's like what, 15 spots, so 105 people is a lot of people to pick from. So we initially didn't have an application deadline, but just due to that, I wanted to be fair to those who applied a little bit faster.
It's amazing. I'm really excited about that. Great. Well, thank you. Any other questions or thoughts?
How many of those 15, how many have to be like, we have to have family members, we have to have family members of children. How many are like determined by a specific, like how many are just whoever happens to qualify with lived experience? Just curious. Do we know?
I don't have the statute in front of me, but I can get that to you. There are specific numbers, but then there's also the totality of everyone we have has to hit the 51%, right?
Yeah.
So some of it is just like making sure there's even numbers, right? And trying to balance that.
State as well as
Yeah.
important.
Yeah. No, so I think we have a pretty good variety of ideas of different participants. But if anybody has any special groups that they would want to make sure we can try to include in MHAPAC, because we do want to get a good representation of humanity as a whole, all the different scenarios. There's, if you need it for some reason. Okay.
I was actually looking at return calls and email if they did provide a phone number, even though we asked for one, some people did not. Just to confirm they're still interested and just get an idea of what groups they represent that we may not have added to the application.
Okay, thank you. Thanks, and I'm really excited by the response we got. That totally surprised me in a wonderful way. So thank you. Yeah.
Good problem to have now.
Yep. Yep. Okie doke. And Stephen. There you are. Yep. Talking about the mental health block grant.
Okay, I wanted to give a real quick update on our mental health block grant funding, including two supplemental funding awards we recently got. So just as a reminder, we just put in the application and it was a full application this year. We finally got the final numbers as well. So this year's mental health block grant is, as you see, just over 18 million. That's actually a bit of a reduction from previously. It's something that we expected, and it's not even quite as much as I had expected. So overall, I think it's pretty good news. We've got the 10% FEP and ESMI set aside, the 5% crisis set aside, and a 5% admin cap on it. And a lot of this is information we've talked about just as kind of reminders of our set asides. Reminders of our priority areas. So for the mental health side of the application, these are our priority areas along with what we're looking at. So we've got older adults. We're going to be looking at the coverage across the state and counties, clients, and how many subject matter experts we have in the aging space. For first episode psychosis and early SMI, we're looking at clients served through primarily our first episode psychosis programs across the state. Crisis response services is looking at the number of mobile crisis sites we have. And increasing those, I think up to 17, if I'm remembering correctly. Disaster behavioral health is looking at the number of rest teams we have.
What is a rest?
I knew you were going to ask me that. It is something that I can look up and let you know later.
Okay.
I do not remember. I apologize.
That's okay.
Anyone? Ari? What's it stand for? Okay.
They do post-venture response.
We'll look that up and let everyone know. Yeah. Recovery community organizations looking at the number of RCOs with Fidelity. Access to recovery services, we're looking at clients served. For Indiana clubhouses, we're going to look at the total number of accredited clubhouses. And for peers, the number of CPSPs. And thank you to Matthew on Teams for resilience and emotional support teams, REST teams.
Oh, okay.
So for our first supplemental funding we have is the Bipartisan Safer Communities Act. This is our fourth round of mental health block grant supplemental funding. We've been told this will be our last round of supplemental funding for the BSCA. It goes from 9/30/25 through 9/29 of 2027. We've got just a bit over $1.4 million. And the things we are focusing this funding on is early SMI human trafficking treatment trainings, best practices with human trafficking in that early SMI stage, so that, young adult area. SED mentoring and mental health, specifically in Bartholomew County, partnering, that's a continued program that's happening there. And then support for our suicide prevention statewide plan. And again, that'll be one-time funding. And then the other one we have is based on an executive order of ending crime and disorder in America's streets. So this one, we got the award on 9/17/25, and it lasts through 9/30 of 26. We got $432,000 for it. And we're going to be sharing part of that funding with Court Services Office of Behavioral Health for assisted outpatient technical assistance, the toolkit, and a competency evaluator directory for the court system. So really focusing a lot of that funding on the AOT system across the state of Indiana in partnership with Office of Behavioral Health. I know there was a lot of information that I went through with the mental health block grant funding and some of the things it'll fund. Any questions that I can answer on that?
Can you send that out?
Yes.
Okay. He will be sending out those slides.
We got a request to try to talk. Can you hear us now?
Yes, we can.
Okay, sweet.
Oh, yeah, the RCOs, are those are usually substance use focused, correct? But that was under the behavioral health, like the mental health block grant option of it?
So with a lot of the RCOs, the peers, everything like that are splitting the line between our mental health and substance use in terms of the priority area. So I wanted to include them on there to get a full picture.
Okay, thank you.
Okay. Thanks so much.
Thank you. Thank you. Any other questions or thoughts? Okay.
Thanks.
And this will be okay, CCBHC discussion. So always excited to hear what's going on in that world.
Yeah.
As it expands, hopefully.
Nice. Yeah. All right. So we'll have a discussion on CCBHC. And first and foremost, I would like to start with an overview. Yeah. Good point, Sarah. Thank you. My name is Ari Nasseri. I'm the Assistant Director for Systems Transformation, which really means that I help out Sarah and Becky and everyone else on CCBHC, as well as the guy behind the Wizard of Oz. Yeah. First and foremost, just going to give a short introduction on what CCBHC is, because I think there's continuous, questions about exactly who is a CCBHC, who isn't. There's a lot of different grants out there. So first and foremost, one of the key things is CCBHCs are a proven outpatient model, and they've been in demonstration under CMS for quite some time. It started in 2014. States were slowly allowed to join. An initial cohort of 10 started, and in 2022, we saw the opportunity was opening up for states to join, and we prepared and successfully were awarded entry after some work was done, quite a bit of work, not some, to get entry into the CMS demonstration. So we were awarded in 2024, and we went live in 2025. The Senate Enrolled Act 1 of 2023 is what gave us the mandate in order to be able to do that. That's why it's listed here. And generally, CCBHCs do several things, but the three key things are they ensure access to integrated care services, including 24/7 crisis, as well as crisis stabilization and medication-assisted treatment. There is also strict criteria that revolves a lot of different aspects, from governance to access to the services that are provided, the staffing, and how things are funded, and the care coordination with different services. And then they receive funding, and this is one of the bigger changes that really makes the rubber meet the road. They receive funding to support the real costs of expanding services and to capture all the costs of their care. And that's paid for through a prospective payment system, which is a drastic difference from fee for service, where you're billing each service that you can bill under the state's plan and receiving a certain amount. That changes the way that hopefully they approach it. And instead of providing services in a way that meets the fee for service model's ability to meet their margin, they are able to provide services in a way that meets the individual's needs and treatment plan, and allow the PPS to cover the cost of those care. Moving on to the next slide. And so that's what this really captures here, is that change in the fiscal model. So taking what was a bunch of different funding methods that under fee for service and combining them into one daily rate. This simplifies it in terms of how they're supposed to bill, and then therefore should simplify the way in which they are able to provide services without thinking about the billing aspect to a certain degree. There are aspects that they have to think about when it comes to the cost report, which is a part of the building of the PPS rate. So in that cost report, they go through everything from the staffing to the administrative costs to the allocated costs. And that's how they build that PPS rate. And that's done in conjunction with a couple different things. The community needs assessment is where it starts. They look at what the community's needs are. They're supposed to work with other folks in the community in order to put that assessment together. From there, they build a staffing plan that is supposed to now describe how the staff that they need will meet the needs of the community. And then from there, they build the cost report by also looking at previous encounters from the year. And that allows them to hopefully be able to forecast what the real needs of costs are for providing care in the community. And then that PPS rate is a daily rate. So every time they provide a billable service, they're given that PPS rate. Well, not given, they're paid that PPS rate. And then that should cover all the costs of care, including those costs that are not captured by those billable services. Moving on. And so here, a few different things are on this slide. It's a pretty big slide, but first and foremost, it shows the comprehensive range of services that are provided. A lot of these are ones that we may naturally think of when we think of CMHCs, who are our current safety net providers. And those are going to be things like psychiatric rehabilitation services, outpatient mental health and substance use services, some of the screening that occurs, but there's some additions in terms of outpatient primary care screening, the heavy push for more peers throughout the workforce, crisis services, targeted case management, community-based mental health care for veterans. Those are all relatively new to the CMHCs. So those are enhancements that the CCBHC model provides and offers for folks to provide. They also have a series of metrics that they have to provide, 21 total quality metrics and goals. Of those, 10 are required and 13 recommended evidence-based practices, but they have to provide all of those evidence-based practices that we require. They have to be able to provide them, as well as those required metrics and goals. They have to be able to report them to us at the state, so then we can report those clinic collected measures, as well as the state collected measures that we collect through claims and our data system Dharma to CMS. And so that's an annual process where we collect and then share it. And there's quarterly check-ins to make sure we're on track. But annually, we have to report our data every year to CMS on what is going on with those 21 metrics. And then the map shows the 8 providers that joined our demonstration as our initial cohort. These are the 8 providers that are CCBHCs designated by the MHA. And that's an important distinction because there are still folks who have had or currently have CCBHC grants provided them, discretionary grants from SAMHSA. I believe those are all currently wrapping up, but there are a good amount of folks who have had those grants, as well as DMHA has provided bridge grants so that folks can continue operating the services that they built up through those discretionary grants so that they stay ready to eventually apply and possibly join our state's demonstration. So the key thing that I want to share here, because sometimes I hear about, oh, we have a CCBHC here. Not exactly. It's a CMHC who is attempting to eventually become a CCBHC, but these are our 8 CCBHCs that we have currently designated. And designation is how we currently provide the authority, that we as the authority for the State Mental Health Authority provide that they can operate under our demonstration. They have to have that DMHA designation.
So they were all pre-existing CMHCs who are, okay, nothing new created, but yeah, okay.
Yeah.
I thought that's what it was, but I'm not sure.
If you were to make the designation as well, that like a Centerstone operates in more counties than what they're designated for. So there's a little bit of play there. Like they can be, there's a CMHC that operates as a CCBHC in Johnson, for instance, or not Johnson, it's like Bartholomew, whatever. But in another county, they're just.
They're not, okay.
Yeah, so a couple of things there. All of the counties that you see highlighted, and there's 2 that have overlap. The 2 are Owen and Marion. Those are all counties where the providers have been designated to operate as a CCBHC. So they're supposed to provide all the required services. They're supposed to be able to provide 24/7 mobile crisis services, as well as stabilization services to all of those counties. Now, within that, they still are able to provide services under their CMHC NPI outside of those areas for specific exclusions. And those cases are going to be like school-based contracts that they have. Now, SB4 or SEA4 has changed how they provide other services outside of their county. So I think we're going to see that change moving forward because Senate Rule Act 4 drastically changes their ability to provide those MRO and other services outside of their county, except for school-based contracts. So that will be the thing that we see going forward. Oftentimes outside of that designated area, they're primarily going to be providing the school-based contracts unless we give an exclusion The only other times that you'll see them still billing as a CMHC will be other carve-outs that were not blended in with CCBHC. And those will be things like AMHH services, recovery works, those other carve-out programs that don't fit within outpatient provision.
Isn't there a 2-year ramp to that?
Yes, there's a 2-year ramp to that. Yep, but
Just making sure.
moving in that direction. These are all the required metrics. And as you see, there are several that are clinic collected, and there are a swath that are state collected. So we at DMHA, along with FSA and OMPP, do the work to collect the state collected metrics. And this is primarily led by our DMHA folks that lead data, Wendy and the rest of the team. They work through claims as well as our Dharma system to collect those metrics. The clinic collected ones are ones that we work directly with the sites for them to collect the information and share it to us directly through Dharma so that we can pull it all together and submit this annually to CMS. There are several that have some highlights on it, and those are ones that we identified as priority. Time to services obviously allows us to be able to see how fast are folks getting into services. That's an access metric. It looks at the first metric is, did they receive their initial triage and evaluation? And the second one says, did they get a clinical service? So that one looks at that within a certain time range, and that time range is supposed to do that within 10 days. Screening for social drivers of health. That one is pretty explanatory as well, looking at social determinants of health and seeing what is affecting the population. Preventive care and screening for tobacco use. That was one that we had, but that one we changed as a priority. It's no longer a priority. Suicide risk assessment, a priority as well. And then initiation engagement of alcohol and other drug dependence, and use of psychosocial care for adolescents and antipsychotics were ones that we initially chose as priority metrics. But overall, this really shows these are all things that we were not previously reporting to CMS and not previously collecting information on. So this also shows the enhancement of CCBHCs in terms of looking at things from a data-driven perspective. And as we go into the future, we look to enhance our data strategy as well as what we collect and creating more outcome-based metrics that we look at. So some of the things we saw after our first year, because we did complete our first demonstration year in 2025, calendar year 2025 was our first demonstration year. Our demonstration started on January 1st. And so every year is following that calendar year. In that first year, we saw 87% of new patients receive initial evaluation within 10 days of first contact. That's a drastic change from what we were seeing in the field a few years ago, even before we started making this move towards CCBHC. So we've seen a lot of changes as we were prepared for this, for both the CMHCs preparing to do this work. And so I think that's a big reason why we've seen a huge amount of change towards access. Nationally, 70% of new CCBHC patients receive an initial evaluation within 10 days, which really shows that even in our first year, we were able to make some major movement compared to the national benchmarks.
Hey, Art.
Really?
Yeah.
Sorry, I just had a follow-up question to early on. So how many total CHBC, I can't even say it right now, CCBHCs are approved and functioning at the moment? Is it 8?
There are 8 providers currently functioning at the moment.
Okay, and so that's down from like with CMHCs where we had 24 total prior. So
yeah,
like, is there a
23.
significant reduction in coverage comparatively to where it used to be with that big of a drastic cut in the amount of approved providers?
Yeah, so I think a couple points there. I think it's about an evolution, right? And evolutions take time. And if you go back, Stephen, yeah. And if you go back, a couple points there. So first and foremost, it's an evolution that takes time. One of the factors that affect our ability to make this transition is the state's capacity as well as the site's capacity to make this change and to do so in a meaningful way. We do not want to have too many folks that enter the demonstration that are not readily prepared to act and operate as a CCBHC. And at the same time, the state needs to be able to support all of them. A bunch of different factors play into that. The ability for us and OMPP and FSA to support them through MMIS changes, through data changes, all of those factors play into how many we can have in each cohort and really have implement this to the standards that we are setting. At the same time, while we say 8, that doesn't mean there's 8 counties. So each of the 8 providers, to the most part, are serving their approximate designation and catchment area they're serving as a CMHC. So you'll see Centerstone, that big green swath, they are serving their whole region that they were previously serving as a CMHC, but they are now operationalizing everything and becoming a CCBHC. So in those areas are operating as a CCBHC. Similarly, you'll see Adult and Child and Eskenazi are both operating in their current spaces and catchment area. And there are some changes. There's been a couple places where the catchment area has expanded a little bit to include another county. But overall, this is a slow change that we have 4 years to do. So another aspect that I did not mention is the CMS demonstration is a 4-year term. So we have 4 years to do several things. Slowly get everyone on board as a CCBHC, as well as work to develop the demonstration model and criteria a little farther. No one gets it right in the first year in their first attempt and what they submit and their application to the CMS. And so there is some time to make changes before we move forward towards a SPA or a waiver in order to solidify this as a model that Indiana's Medicaid pays for. Does that answer your question?
Yeah, no, that's helpful. I appreciate it.
Sarah, did you want to say something?
Yeah, I was also going to say that Indiana chose to, in order to be a designated CCBHC, you have to be a certified CMHC first. So in Indiana, only our CMHCs can become CCBHCs.
Yeah, no, that makes sense. And
Okay.
yeah, it makes sense that the numbers are working out good too. If we have all of our old CMHCs still up and running, plus the CCBHCs taking on
Yes.
new, it's able to supplement some of that until it transitions. So, okay, thank you.
Of course.
So would there still be any potentially new CMHCs starting, or is everything from here on out going to start going into the CCBHC model?
Correct.
Correct. The latter.
The second
Yeah,
part,
second
automatically.
part,
Okay, okay,
With the
Good.
goal to have all 92 counties covered.
good. Okay.
All right, and this is an example of how we are looking at those metrics that I talked about earlier. So here you'll see a couple different colors and gradients, but really what we're looking at are how are folks doing in terms of screening for the total that they've completed and eligible and the amount of compliance that they've had. And then from that screening, how are they doing and following up to that screening and actually addressing the conditions that they saw that screen positive as, whether it is depression and creating a follow-up plan, or providing brief counseling or providing tobacco cessation. This allows us to take a look to see, first and foremost, are they doing what they're asked to do in terms of screening? And then are they following up with those individuals? Also down below, you'll see that there's the breakout of the 2 pieces of the iServe metric, which we saw as a priority, which was the days from first contact to that initial evaluation and the days from first contact to that initial service past that initial evaluation. And that's why you'll see 2 days and then 12 days. So it's saying that this example of a CCBHC that's unnamed was able to get folks across the board on average within 2 days of their first contact to an initial evaluation. And then on average from the first contact, they were getting the first clinical service within 12 days, which is a marked difference from what we were seeing a few years ago.
Any difference when you say unnamed, which you get with maybe some of them that are providing that were approved for the less populated counties, if their metrics are a little bit different for first contact assessment, because clearly most counties in Indiana do not have public transportation.
Yeah, so we do see differences, but oftentimes I haven't seen the pattern be rural versus urban. The pattern has been more about how they operationalize their access. There was a variety of different things. A vast majority of them ensured that they had same-day access available in order to meet the needs of anyone that comes in quickly. There were cases where other ones had ensured that their weekend hours really met the needs of the population and ensured that they could get folks in by the end of the week for services. And so there's a variety of different methods that they chose to employ and also the staffing metrics that they employed. That's, I think, the bigger difference in how they've done. And then I think it's always about the outliers, the folks who maybe come in and request a service and then don't show up, and how they're able to engage with those folks and get them in quickly when they don't show up. That, I think, actually makes the biggest difference in where they end up in terms of whether it's 2 days or more. And then a couple other things, looking at that screening and follow-up for clinical depression. Here we saw that the CCBHC's average for 2025 was 77%. The national average that was found in the impact study from 2020 from the National Council was 51%, so above that national benchmark from a few years ago. And then the CMHC average in calendar year 2025 was 15%.
The school-aged children being assessed primarily.
That is a good question. I don't know if I know the answer of where they're being
Like
assessed.
School or medical care providers. I was just.
It's a good question. I think we can take a look at that. And then in terms of where, you mean like whether it's a clinic, in a school, or at their home?
Yeah.
Yeah,
Like,
we have not looked that deep into where, but we could look at the place of service codes and identify that.
Okay, because I keep hearing of more and more schools becoming involved now in kids' mental health care, which I think is good. As long as they follow through.
Yes.
Yeah.
Yeah. And then here, screening and counseling for unhealthy alcohol use. Again, similarly, there was a 62% national average in 2020 from the National Impact study. We in Indiana in 2025 had an 88% metric here, while the CMHCs had a 20% average. Forward. And then here, so in 2025, we looked at how all of the sites operationalized their staffing metrics and what difference it made going to CCBHC. And what we saw is that across the board, in preparation as well as during that first demonstration year, there were 488 key staff individuals hired across all 8 pilot providers. That's a large increase in certified peers at 95, 66 nurses, 39 navigators, 11 nurse practitioners, PAs, APRNs, CNSs, 9 psychiatrists, 7 psychologists, and then 261 licensed clinicians and other mid-level professionals. So overall, we saw quite a bit of a workforce expansion, and this goes at them looking at their community needs and then reevaluating their staffing plan in order to meet the CCBHC model, which really is about meeting the needs of the individuals that are seeking care in their community.
Is there any educational funds being provided to people to help obtain?
So in terms of educational funds, I think that is something that some of the sites may have looked into, but overall, it's more about collaborating with local entities such as universities or areas that can help pull folks in at an early stage. And then also the other aspect is with those 10 required and 13 recommended EBPs, as well as the required trainings, those are pieces that the CCBHCs have to include in their PPS cost report. And in addition, the state is working on a center of excellence to look at the fidelity and TA that's available for those EBPs. And so those are the ways in which training and education is supported in CCBHC.
Like people who are interested but can't afford it, let's get them some funding.
Yeah.
Hey, Ari,
Yes.
just a quick question on the last 2 slides. Is there anything that you guys are like contributing to that much of an increase, like going from 15% to 78% and 20% to 88%? What like, what are we saying is making that significant of a difference
Yeah. So
between these things?
great question. Honestly, it's two real pieces. One, it is about identifying what the state wants to look at, right? And so being data driven, also as we define what metrics we're looking at, what measures and how we're evaluating the CCBHCs, they feel that. And so they want to go ahead and ensure that they're meeting those metrics. And so that's a piece of it. The other big piece of it is when we are not, by looking at these metrics, we are able to actually record them. And so it's possible that the CMHCs were doing this in the past, but the data wasn't being recorded and it wasn't being documented in a way that we could display it. And as we all know, if we don't have the data, then whether or not it's occurring is in the air. So I think it's those two factors more than anything else that of why we see the stark difference from the CMHCs to the CCBHCs.
Okay, yeah, no, I really appreciate that because it did seem quite drastic and I was a little concerned, but yep, that makes sense.
I just wanted to see if Christine, if you had anything to add to that as a CCBHC pilot site?
Yeah, thanks, Sarah. Actually, I was going to say
Yeah.
the exact same thing that Ari just said. So I agree. You know, anytime you have an expectation, I mean, you're going to focus on it very clearly. Not that it wasn't in our list of things we did, but yes, so the focus is there. We know it's needing to be done. Also it was okay, let's collect this data correctly. And we actually found that we were not collecting data correctly. And that really impacted, of course, our numbers. So once we got that figured out, we realized, okay, we're doing a lot more than we thought. So yes, I just agree with Ari. So nothing new to add.
Thank you.
Appreciate that, Christine. I'll remember that and you guys get an extra star.
Thank you.
And then here, want to highlight this as well. So the CCBHC model in that 2023 Senate Enroll Act, one of the key things there is it really tied CCBHC to crisis. And the reason that that's important is they do have a direct overlap and foundationally they work well for a transformation of how we provide services. CCBHCs provide direct support to two of the 988 and crisis pillars, which is someone to respond and somewhere to go. So CCBHCs have to be able to provide 24/7 mobile crisis teams in their regions, meeting the designation that DMHA put. So 1 hour in urban environments and 90 minutes in rural. On top of that, they have to be able to provide stabilization services. The state is currently working on a designation for stabilization services, and I think that's something that we'll see continue to evolve over time as our system evolves. But overall, the metrics that we have that really show this direct connection is that in calendar year 2025, 15,038 individuals in crisis were served by those new services from CCBHCs. And of those 15,038 individuals that were served through CCBHCs, 2,617 of those were referred to law enforcement. So that's something that we really wanted to highlight as well.
Can you clarify? They referred to law enforcement or referred from law enforcement?
From, not to.
Oh, thank
Yeah,
you.
yeah, yeah. Very.
You sound too- I was thinking-
My apologies. My apologies. That brain to mouth connection is not the best for me. So apologies. Yeah, so that is a consistent work in progress. There's a lot of work being done on multiple sides at DMHA. So this is something where CCBHC really supports the foundation and provision of those services, but the crisis team as well really pushes connection with law enforcement through those crisis services. And it is a bit of as you build it, they will come too. One of the biggest factors that we've seen in this space too is once the law enforcement learns, and it is a huge amount, in all honesty, it is all the work the crisis team has done to push CIT training across the state, which has been a slow push. But all these things compound into momentum. And what really pushes the law enforcement agencies to trust the CCBHCs and other crisis providers more is when they see the operational effect. If they can come and drop off someone and reduce their amount of paperwork and do that within 10 minutes, they're more likely to do that in the future. And we've seen that over time. In those spaces where CCBHCs or other crisis providers stand up and then are able to start taking in those referrals from law enforcement through, especially if they have a direct door for law enforcement and first responders to drop off those individuals, that's when we really see that connection start to ferment a little more, because it takes a little time. They're not really 100% ready to trust always as they first start to see it enter their county. And there's a variance there. Some of them are jumping right on board. Other ones are more reticent, want to stick to their own policies and practices until they see the efficacy of it. And once they see that efficacy, that's when we usually see them jumping more and more on board. And so, yeah, now I'm going to have a couple points. One, demonstration year 2. So we're in the middle of it, March 2026, entering that first quarter. There's a lot of things that are going on in the background. I have 4 bullet points, but this could have been, multiple slides of what we're doing this year. MMIS billing changes. So we just went through a phase 2 of MMIS billing changes and working through all those changes. But there was a lot of work that was done to ensure that that got done. There are publications that are coming out. So we have a manual for CCBHC providers that we've drafted and is awaiting publication by the OMPP publication team. We're also changing it up a little bit this year. In the previous year and years prior to that in 2024, so 2024 and 2025, a lot of our guidance and materials came out through conversations directly with the CCBHCs and information that we would share through messaging. But we are changing that a little bit more to have anything that's regarded billing or how services are to be provided to be done through IHCP publications and bulletins. So that is another thing that we are changing up in terms of how we are approaching messaging that information. Care coordination. So there are several pieces that we identified that we wanted to start to enhance in terms of care coordination of how CCBHCs operate and interoperate within their communities. And these are things that like OTPs that are in their area, FQHCs, especially because CCBHCs can do primary care screening and monitoring, but they don't have the authority to provide primary care services. So that's an example as well. There is work that I think we need to do in terms of how we connect with VR as well as through clubhouses. Honestly, the list goes on and on and on. Peer recovery hubs and organizations. The list is long and plenty, but these are things that are slated for us to start to address and define more in this year. And then data and service definitions is here as well. So we had the data day where we brought all the CCBHCs in to review how things went in 2025, how they felt in terms of the data definitions that we have provided, and what needs further defining and alignment, because there was some operational difference in how folks were doing things based on how they were looking at the data definitions that we had provided. And so there's a lot of learning lessons after that first year that we're adjusting and seeing that there's some further defining needed for data as well as service definitions. So there are several services that we identified need some further definement or defining in order for folks to really be able to operationalize them in the way that we expect and the standards that we are hoping to have. And then another big piece that's on the board, and there's some room for us to walk up to it, but Senate Enroll Act 222, that Senate Enroll Act and the large amount of other things that it did also provided the ability for DMHA to build out certification for CCBHCs, which is another level of authority that we can have in order to make sure that they're providing services in the way that we see fit. Apart from that, if there are ever any questions about the CCBHC model, what's going on in the space, please feel free to send it to ccbhcquestions@fssa.in.gov. That is the best way for us to capture it and make sure it goes to the right person, whether it's Wendy, who leads a lot of our data work, whether it's me, if it's something that I can answer, or any of the rest of the team members. That's just the best way for us to make sure that we're answering a question and capturing it for others to know too, if they need to know that answer. Apart from that, here for any other questions.
What a wonderful amount of information. If you could just repeat the whole thing so I can absorb more of it. So is going to be common standards. I'm an RN, so I'm used to like working in a hospital system. There's going to be common standards. What kind of time frame are the CCBHCs being given to all meet the common standards? So people, because with the mobility in the world, when they go from place to place, moving and stuff, I want them to be able to expect the same care everywhere. So what kind of time frame are we looking at for meeting those standards?
Great question. I think it depends on which standard we're looking at, right? Now we want everyone to be provided care the same, whether they go from one CCBHC to another. That is a goal that we have. But in the building of this, there's a timeline for everything. And a great way for me to capture this is like the data definitions. While we had provided data definitions, we realized after reviewing the first year that there were some gaps in variance in alignment to what we saw as a standard. And a lot of that is the back and forth of us providing a description and then realizing as we're talking through how it was operationalized that maybe that wasn't defined detailed enough. In addition, there are things that we are still working to build, such as the care coordination policies, the definitions of the templates that they're supposed to have between each other, things like the center of excellence, what fidelity means. And so one thing that we are very aware of and conscientious of is it takes time to right the ship. And they're rather large ships. So we want to make sure that we're building reasonable timelines for each of these changes that we announce, that the CCBHCs are able to meet them. And at the same time, being able to walk that back from if we're making any major changes, that has to be reported to CMS. And so each major shift has its own timeline. But in the end, what I can say is, in the other pieces, every year we might notice something that needs further defining or change. But we have these 4 years to specifically be able to ensure that by the end of it, we have that standard set for everyone across the state before we go into SPA or waiver.
Okay, thank you.
Yeah, of course.
I think Mike had a question on here, and then I had one quick one too.
Hi, Mike Shorter, Clubhouse, Indiana. I get maybe it goes along with the care coordination. Hi, question, but any talk about reopening the doorway for DCO agreements?
Yes.
Oh, great. So that's a concern of some of the clubhouses that I work with. And I, again, appreciate you mentioning us and as part of this transformation. And I'd love to have a meeting sometime in the near future.
Absolutely, absolutely. It is on my list of things to do to meet with you and Nikki. Now, I will say this: when it comes to DCOs and those other pieces, this is one of those learning lessons, right? We constantly are working with the sites to make sure that they understand what's going on, but they also learn things as they go through them. And so we had a good amount of sites, I think 2 in particular, who said, "Ooh, after the cost reports were developed, we really would have loved to have a couple DCOs." So designated collaborating organizations, that's a type of care coordination agreement that has a formal business partnership, where in this case, if the DCO was a clubhouse, the clubhouse would enter into that business relationship with the CCBHC. They would provide services on behalf of that CCBHC, operating as a CCBHC, collecting data. All of that information is worked out into a business agreement where the CCBHC then pays that DCO a set amount. They capture all the costs within their PPS rate, and then they're able to operate as one. And that is why I say the time for folks who are going to want to create a DCO relationship is during a process called rebasing. So during that rebasing process, that's when they have a time to relook at their cost reports and make changes, should they like to make them, as well as take a look at how encounters were provided in the year before, and then reevaluate that PPS rate. So it is right before we go into rebasing, that year before, that those discussions should happen. And the other time is, let's say we're talking about another cohort. Before that cohort develops their PPS rate, as they're going through that community needs assessment, as they're developing their staffing plan, that's the time to have the discussion about a DCO relationship so that they can incorporate those changes into their staffing plan and their PPS rate. Does that answer your question, Mike?
Kinda. I think maybe
Okay.
if we're gonna get into specifics, I'd like to talk to you a little bit more, not take up all the air in the room. But we had some 3 clubhouses that were in the middle of a negotiation, and then that didn't happen. They got word that there weren't going to be any more DCOs, and I'm not sure where those 2 examples that situation fell. But it's a longer conversation. I don't want to take up your time, but I'd love to talk to you more in detail at your convenience.
Yeah, we'll talk quickly. I'll connect in the next couple weeks.
And then I just had a quick question on in 2026 or 2027, when do you see like cohort 2 and some new additional entities coming on board?
Great question.
Good question. We're asking that question too and determining it through conversations internally. When we know, we will let you know.
Cool.
Is that a fair answer? I think so. Yeah.
Probably the best, but you know, best you can give right now. Yeah, will these things also be coming out, slides? Can it be sent out?
Yeah,
Okay.
these ones all can. Yeah, they've all been seen publicly.
Because would like to be able to lower.
Of course.
Cool.
All right. If there's no further questions, thank you all for your time. Appreciate it.
Thank you. Yeah.
And I think I saw our next. Yes. Hi. I think Stephen's gonna load your slides for you. What would you like to clear yourself? Or would you like him to change the slide?
He can drive. That's fine.
We'd like to welcome, I'm assuming this is Liza. Okay, that's the name up there. Great. Well, thank you. Thank you for joining us today. And I always love the I'm always like hearing the legislative updates. I may not always love them, but I like to hear about what's been going on. So thank you.
Thank you. Thank you for the opportunity to be with you all today. I am Liza Sherman. I am the agency Family and Social Services Administration's Legislative Director, and I am joined by Kara Scott. I'll let you introduce yourself.
I am Kara Scott. I am the Deputy Legislative Director with FSSA.
So Director Saylors asked us to join today just to provide a recap of this past legislative session that just wrapped up a couple weeks ago. So we will walk through some pieces of legislation that impact, this is specifically viewed from a FSSA DMHA lens. This is purely informational, not meant to be legal advice, all of those necessary disclaimers, and is to be informational, right? And so we'll walk through these. The first one I want to share about is SEA 1. This is the Human Services Matters bill. So this bill includes a lot of elements that are in conformity with the Working Families Tax Cuts and Jobs Act, HR 1, the Big Beautiful Bill, whatever preferred title to the legislation at the federal level you prefer. SEA 1 makes a lot of conforming changes. And also includes some other changes regarding codification of the Rural Health Transformation Program Fund. So the RHTP for short is a $50 billion grant program that Congress passed in the Big Beautiful Bill last summer to drive investment in healthcare in rural communities. And so FSSA is working very closely with the Department of Health on that grant project that will span the next 5 years. And so the legislature codified the fund and additional legislative oversight of the uses of those funds through the State Budget Committee. The bill also codified what is referred to as Smart SNAP changes. So restrictions on the use of SNAP dollars
to incentivize healthy grocery purchases. The bill terminated expanded categorical eligibility within the SNAP program, and then aligns some immigration eligibility categories with HR 1 and makes codifies work requirements, eligibility checks for that, compliance checks for the expansion population specifically within Medicaid, and make some other technical co-payment changes in alignment with HR 1. We'll turn it over to Kara to walk us through what passed in SEA 4.
Can I ask a quick question? Does FSSA have the staffing to start checking everybody quarterly?
So from an administrative, we're still working out the implementation side, the administrative side, working through what those administrative needs will be. But it will be an increase in manpower from HR 1 alone will be an additional increase in staffing need, and then SEA 1 as well. So some of it's driven by HR 1 and then additional requirements in SEA 1.
So they're going to take care of those, meeting those needs so those things can be achieved and funding for it and stuff. Okay.
Thank you. Okay, I'm going to run through the next couple. First up, we have Senate Enrolled Act 4. This was kind of a big fiscal matters bill, so our summary here is specific to the mental health space pieces from that bill. The first key change that it made was it added language to allow counties to meet their local CMHC funding requirements with any funding source, but did make an exception for federal funds. Those cannot be used for that purpose. It made a change to the CMHC requirements that they only provide services within their designated service areas, their catchment areas. There's an exception there for school-based services, so those can still be provided outside of their catchment areas. And then it also made some changes to the CMHC reporting requirements. Those are kind of outlined here. That's an existing reporting requirement. It just kind of shifted the responsibility for some of pulling those pieces together to the CMHCs. Next up, the Syringe Exchange Program, Senate Enrolled Act 91. They extended the Syringe Exchange Program through July 1st, 2031, so another 5-year extension on that program. They did make some changes to participation in the program. The first one is participants will be required to present a valid identification, and then they also changed that to a 1-for-1 needle exchange, which is a change there. Senate Enrolled Act 92 allows counties that have a community corrections program to establish a community corrections trust fund. And then it has some additional language that specifies the funding sources that are allowed through this. Some of those allowable options include rehabilitation and education for that funding. And then Senate Enrolled Act 222, this is another one that was pretty lengthy and had a lot of stuff in it. This was an agency initiative for us. The summary here that applies to DMHA is that it adds the 988 Crisis Response Center and mobile crisis personnel as first responders. It granted DMHA the authority to certify and establish standards for certified peer support professionals, and then a similar update to the code that grants DMHA some authority on recovery community organization certification, being able to enforce and uphold high quality standards for participants of those programs. I'm going to hand it back to Liza. Thank you, Kara. And before we leave SEA 222, I saw Steve in the room, so I want to acknowledge Mental Health America's assistance with SEA 222 and the partnership there. Senate Enrolled Act 262 was a bill that dealt with the Inspect program. So the Inspect software system, for those that aren't as familiar, is a database for prescription information. And 262 made some changes to allow for some limited data sharing with the health department, and FSSA also made some alignments with federal requirements to ensure that patient consent is acquired for that data. SEA 285. This bill, we've included it on this presentation just as it's a conversation that I imagine that I know that we will be having more conversations around this conversation as this bill goes into effect regarding housing issues and how programs and partnerships within DMHA can be a part of the solution in this space. And so there were some legislative changes regarding public camping enforcement. And so, yes, have this on our list just as we look towards what are the solutions in this area. I want this to be top of mind. The next one is
what was there a change in definition? Was it previously undefined, or what was the change there?
yeah, so I don't want to mislead on the specifics on the bill. We weren't intimately involved in the legislation, just wanted to include it here for awareness. And House Enrolled Act 1296 was passed by Representative Bascom, authored by Representative Bascom, formalizing some additional registration for recovery residences and authorizing DMHA to post this information online and allowing the agency to seek assistance externally to assist with that registration process. So thank you for the time this afternoon. Just really wanted to use the opportunity to inform, explain, highlight some of the legislation that passed this session. It was a short session, ran from January through, goodness, end of February. Yeah, yes. Short session, but obviously a lot was made it through the process. So I am thankful for the opportunity. Happy to answer questions as I'm able.
I know you said this was more kind of a educational, just telling us kind of what was going on and giving us a brief about them. Historically, I feel like FSSA has asked for opinions from the community and from councils like this on bills that are ongoing. Is less of that just kind of happening with the current administration and expectations around DMHA and FSSA? And we should really look outside of kind of this area to be having some of those conversations?
I think, and I'll turn it over to Director Sailors. I mean, we want that feedback. We want to hear from our stakeholders as an agency from, absolutely. This presentation today, yes, was more informative in nature, but yeah, those conversations I think are still important to have. And Director Sailors, do you want to?
Yeah, I think as we've just started meeting internally, DMHA, to start thinking about how we operationalize some of this, and we will definitely be engaging with those who are in the space to be able to hear, to ensure that we aren't creating policies, right, that cause problems for you guys to operationalize. So I think it's really important that we do hear from you. And I think you spoke about the CMHC changes, right, with the catchment areas and MRO, and we have a 2-year ramp up to do that, but we won't be doing that in isolation without conversations with everybody. So yes, we'll probably be having more dialogue about it.
For sure.
So
And I just
people have
meant,
questions, who should they write to? Like if people here and on the council have questions, where should they? I'm sorry, I was asking her if people have questions, who should they be directed to? I walked into that.
No, but
No, I am not a state employee.
I do think that if there are bills that you're interested in specific to how are we operationalizing those, how can you be a part of the conversation, reaching out to myself or Becky, we would be the great first point of contact to make sure you're included in those conversations.
For sure, that's fine. And some of the stuff
Marilyn.
is super small. I mean, like the bill around syringe exchange and adding in language around needing to have a valid ID to exchange a syringe when you're primarily working with homeless populations that don't have IDs, and just drastically restricting the amount of people who are going to have safe access, and then in turn cause rates of communicable diseases to go up again. Just some things like that, being on the front end of being able to share some of those concerns from a state
As
DMHA
session is going
standpoint.
on? You
Yeah.
mean when bills are being heard? Yeah. Oh, gotcha.
Yeah, just instead of on the back end.
Yeah.
Yeah, and from a like legislative engagement standpoint too, will be in routine communication with the different associations, provider groups at the State House and representatives to understand impacts and those lines of communication. I think still can run concerns through Sarah. She'll coordinate with the legislative team as well. But those always a great avenue to work through different associations or organizations that you might be involved in.
Cool, thanks.
When did these laws go into effect?
Each one has their own effective date. Yeah. So 7/1/2026 is the default generally. However, there are changes like work requirements for Medicaid that will be effective 1/1/27. So and there are further out effective dates too. There are bills that
On the.
Right.
and then some provisions have effective upon passage. So I didn't include effective dates for our presentation today. But it just depends on the bill and the specific section.
It was in the big bill.
1003.
Yes, and then it's hard to explain. It came out of the bill, so it's still in statute.
Any other questions, thoughts? Thank you.
Wonderful.
Thank
Thank
you.
you for the time.
Yeah.
Thank you.
Hey, any other thoughts or questions on anything we've discussed thus far? I know we've got a wonderful boatload of information on several avenues today. And looking forward to seeing all the slides. Any other thoughts or questions?
We had changed the time to 3 to 5, and I just didn't know if that time works best for everybody, or you guys had, may interfere with like after work things.
As I recall, I think that conversation seemed like it was more based around people who we were trying to bring in, since most of us here are doing this as part of work, and so can, make it work.
for it.
Um,
Whatever works for them will work for you guys, pretty much.
maybe, but but I feel like that's what the conversation was around, was trying to
Yeah.
be accommodating for folks who, especially since the hope is to get,
I think that's something we're probably going to somewhat need to have a continuing conversation as we add new members, just to see what's going to work for their lives.
Yeah.
So, yeah.
Does in-person still work? Do you guys prefer virtual?
I think I think because of the public
Yeah.
open door, right? Like you need to be in person and only a certain percentage can be
But I didn't see
virtual
anything.
for,
I didn't really see anything for like, we can talk about it. Okay.
that's correct, Sarah. Yes, right. And there's only a certain percentage that can be online.
I'm happy to
To
send
meet
that. but-
quorum. I'm not an
Yeah.
attorney, but.
Were you all able to hear that? Because I'm really appreciating you all joining us virtually, but I think that is something we'll also have to look at as we get new members, is that we do have to have a certain percentage in person. So just to kind of think about that.
Is that a rule in the,
It's the open door law.
It's in statute.
I can clarify right
I think
here.
it's just something
So
that applies across the board for a lot of different.
Since we're
meetings.
like within a state agency, we have to.
Yes, because you're voting on state, so it has to be open to the public and there has to be certain number of people that are in person, right? You have to have a quorum for voting, those kind of.
So we have to have the greater of 2 of the members or 1/3 of the members. So that would be 1/3 of the members for this group has to be physically present.
Thank you.
Were you all able to hear that
I just dealt with this issue.
online?
we're following, I think.
Okay, okay.
Thank you.
So like what's our percentage there today?
You're making me do public math.
We
Yeah, we
can't
are.
really see how many people are in the room.
2, 3, 4, 5, 6. And then there's
members, right?
right.
It's
Yeah,
not-
so members like 10, maybe 10 members, maybe 10 members. And how many are members? Just raise your hand. It makes it easier. Okay, yeah, 1, 2, 3. Yeah. We have probably about 8 to 10 members today, and eventually be a total of 29. So. I think that's also something we'll be addressing as we talk to applicants and to see what their availability will be.
Makes sense.
Member updates. Who wants to share something about what's going on in their world? Please tell.
Buckner from Buckner's Place. We house mentally disabled folks
Use
and
that.
we are celebrating. I know y'all can hear me because I got.
Well, we want to make sure they can
Okay, I'm
hear you.
sorry. I'm sorry. I'm Lori Buckner from Buckner's Place and this year we'll be celebrating 20 years out in the community housing mentally disabled.
This is Matt with Community Health Network. I just wanted to mention, we have a Susan Lee conference coming up. That's kind of a mental health and addiction annual conference we do. There's limited seats left. I think there's only like 10 spots left if anybody's interested. But Nick Sheff, who's the writer of the book Tweak, that the movie Beautiful Boy with Timothy Chalamet and I forget the actor who played his father, Steve Carell. So Nick Sheff is the keynote speaker and a really good conference about future, past, present of addiction treatment coming up on April 17th. So if anybody wants more information, feel free to reach out to me or just Google Susan Lee Conference. It'll pull right up for you.
Thank you. Barb, you want to say something about the Criminal Justice Summit?
Well, we just held the NAMI Indiana Mental Health and Criminal Justice Summit earlier this month. It went well, I suppose. We actually had quite a few people talking about the oh gosh, it's escaping me right now.
285.
No, not 285, around the competency. And that had some really great feedback. So it was a good crowd. We also, March is Criminal Justice Month. And so we have also, NAMI has released a new guide on going through the criminal justice system with a mental health condition. So we have several guides. That's one. We have a navigating a crisis guide. We have navigating college guides with a mental health condition. So if you're looking for some guides on some things, we've got a few.
And did they come out with something recently for kids? It seems like I saw a blurb about some new.
Oh, there's a bunch of new stuff for kids.
Okay, never
A
mind.
bunch.
Okay.
We've released some ability to build curriculum for teachers. It's obviously research-based, and teachers can build curriculum for, I think it's middle and high school
Okay,
teachers. And
yeah.
then we've got some new things for elementary, like there's a bunch of stuff.
Yeah. Good. Okay.
I was just gonna plug the Heather Rodriguez Mental Health America of Indiana, the monthly.
Make sure you talk into the microphone because that's how the people online are hearing.
Can you all hear me up there? Yep, okay.
We can hear you.
I
great.
just wanted to plug our monthly recovery network meeting is this Thursday from 12 to 1 via Zoom, so I can send the link if anyone wants to join. Thanks.
And anybody in the back, I mean, you don't have to be a member to share information about what's going on with you. So it's like to know. Okay, any information more coming from the online crowd?
No, I think I can just add to the CCBHC discussion. So Sarah pointed out where Adult Charles has been a CCBHC now for a year and 3 months already. And I just wanted to thank DMHA. It's been an incredibly collaborative relationship in getting this going. And it really is the largest healthcare transformation that we've seen in decades. So it's just improving access, and we can see it. I'm still seeing patients in the clinics, and you can just tell the difference in access and crisis response and all the things. So just wanted to tell everyone who's in DMHA out there, thank you very much. And we're just excited to see where it's going to go in the future.
Thank you. That is great to hear that. There was something I saw online specifically about the CCBHCs, like within the last few weeks. Does anybody remember who put that on, and did anybody else see it? Because I thought it was very good.
That might have been the Indiana Council CCBHC Year in Review webinar?
I think it was the council, yeah.
Okay.
Yeah,
I heard a lot of good feedback about that too.
Yeah,
It
that's
was
on
good.
YouTube. So it's I call it our 15 minutes of fame, but it's a 2-hour, I think, webinar. But it's so impactful because they have multiple people speaking that impacted them directly. There's a sheriff on there. All the 8 CCBHC sites speak about the impact they've seen. So if you have some hours to spare or break it up over time, but I think it is really helpful. And to me, it just shows on a more personal level, how we're seeing the change with CCBHC.
Yeah, because to me, that's what it comes down to. This is people's lives. And yeah, it was great. I was really glad that I'd gotten information about being able to see that. So lots of good things out there. I think we are still theoretically meeting quarterly. Okay. We don't have a specific date yet for our next meeting, but as soon as we do, we'll be sending that out to you all. Anybody else? Anything coming up in your world in the next 3 months before we meet again? Conferences, meetings, anything like that? I have one question. It's actually something I'm probably going to bring up to talk about more at our next MHAPAC meeting. But on 988, with the 3 aspects of it, how many counties do we have all 3 of those in place? Do you have any guesstimate?
So we have mobile crisis in all 92 counties. You have someone to call
Right.
in all 92 counties.
Right.
So we have 24 CRSSs across the state, 24 CRSSs across the state.
And that's the response teams?
So that's the somewhere to go.
Oh, good.
So,
okay.
yeah. Mobile crisis, the response teams, we have all 92 counties.
Okay. Yeah. So 92 call, 92 response teams, 24 places to go. Okay.
Yes.
And we're working on more of the places to go?
I think we're working to determine what's the volume that's needed, right? And
Okay.
how far can people should be able to drive to one, right? Or to access one, how far is too far?
Okay.
Yeah.
Because sadly enough, I met somebody the other day who didn't know what 988 was, even though I've been on that bandwagon for however many years. So just please keep spreading the word about 988. So because I think it's wonderful, and I think hopefully it's a mutual support between the state's systems and 988, and it's something that works together and can benefit each other. And yeah, so. Okay, you get an extra 33 minutes of life outside of a meeting. So thank you all very much for being here today. And thank you to all the presenters.
I know.
Take care.
Thank you.
Thank you.
I was like, that worked out.
You there for me.
Thank you.
Thank you.